The following podcast is part of a certified educational activity titled Fine-Tuning the JAK-STAT Pathway in Psoriasis, Safely Targeting the Underlying Mechanisms of Disease with TYK2 Inhibition. Access the entire activity and complete the post-test at peerview.com/CCT860. Downloadable slides and practice aids are also available.
Hello, this is Dr. Kenneth Gordon. I'm the Chair of Dermatology at the Medical College of Wisconsin in Milwaukee. Welcome to this educational activity on psoriasis. Joining me today is Dr. April Armstrong from the Keck School of Medicine at the University of Southern California in Los Angeles.
Hi Ken, it's great to be here today.
So we all are familiar with the signs and symptoms of psoriasis. It's a chronic immune-mediated disease with skin diseases that greatly impact the quality of life of patients who suffer. It affects about 8 million, a little over 8 million Americans, with a prevalence in African Americans about 1.5% compared to 3.6% in Caucasians. Interestingly, and I think more evidence is coming to the fore, that psoriasis is likely underdiagnosed in our African American patients, mainly because of differences in the way the skin of color looks in the clinic. Patients with moderate to severe psoriasis experience a greater negative impact on their quality of life than people with minimal disease. But I have to say that in my experience, and I'm sure with Dr. Armstrong's as well, that patients with even limited disease can have major impacts on their day-to-day lives. Patches of psoriasis present as well-demarcated red scaly plaques that can be anywhere on the body, but that will vary based on the type of psoriasis present, places the psoriasis appears on the body, and the total volume of the psoriasis on a patient. We like to think of psoriasis as major subtypes. The first and by far the most common is chronic plaque psoriasis that you can see in the upper left-hand corner of this figure. That's where you see the well-demarcated red scaly plaques. Guttate psoriasis is usually viewed as small coin-like lesions that can occur anywhere and all over the body. Oftentimes they'll occur in crops that happen after an infection, for example. Postular psoriasis comes in a couple of different varieties. The most common that we see is palmar-plantar pustular disease, where you have pustules with or without plaque psoriasis on the palms and soles. But you can also get eruptive or major areas of pustular psoriasis that show up as sterile plaques, sterile pustules on erythematous bases, and that can be anywhere on the body. And finally, erythrodermic psoriasis, which is defined as greater than 80% of the body's surface area involved. This doesn't always appear to be the same as plaque psoriasis, with a deep red view and maybe finer scale than the thicker scale that you see in normal plaques of psoriasis. These patients, as long as sort of the explosive generalized pustular psoriasis patients, can be quite ill with fevers, chills, and feel quite poorly. There are some special sites of particular interest in psoriasis that are often lead to specific challenges for treatment. One of those is inverse psoriasis, psoriasis in areas that include the inguinal areas, the perineal, the genital areas, and some people even include the face as places where we view as inverse psoriasis. These are characteristically well demarcated, but the scale and the nature of the scale is a little different, with a smooth, shiny plaques as opposed to the thick white scale that we see with psoriasis. Oftentimes, this is misdiagnosed as intertriginous fungal or bacterial infections, or even eczematous or contact dermatitis. Sometimes these can be complicated by excess yeast agents, for example, but we have to always keep in mind the underlying pathophysiology is still psoriasis. Nail psoriasis is another area that's particularly difficult to treat, oftentimes associated with psoriatic arthritis. There are multiple different ways, multiple different areas that would involve psoriasis. There's matrix psoriasis that generally shows itself as pitting. And then there is psoriasis of the nail bed, where we can have onycholysis, where you have lifting of the nail bed, subungual hyperkeratosis, and red spots that are called salmon patches that have, or also oil drop spots. All of this can lead to nail thickening, crusting under the nail, nail plate crumbling, and dystrophy that can be incredibly disabling and distressing to patients with nail psoriasis. Palmar-plantar psoriasis is a particular challenge without great therapy to date. It involves the palms and soles with erythematous hyperkeratotic plaques that might resemble plaque psoriasis, but can also have other elements that are very, very difficult. Fissures are often painful and quite disabling. And when you think about walking on fissures of psoriasis, it can be very difficult and have major impact on work. Concomitant nail psoriasis is common. And it's controversial if palmar plantar pustulosis is a part of the psoriatic pathway or distinct, but it can occur with psoriasis, and plaques of psoriasis on the palms and soles can also present with pustules. So sometimes it's very difficult to make these distinctions in clinical practice. The most common lesions of locations of lesions with psoriasis varies and has been described in many different ways. The scalp and the elbows and the legs, the knees particularly, have been generally considered to be of particular import. But, for example, genital psoriasis is probably highly underdiagnosed. A, because physicians don't like looking in those areas in the common practice, and B, patients don't like showing it to physicians. And so probably genital psoriasis is significantly underdiagnosed. I would say in my practice, palmar plantar psoriasis is becoming more and more significant day to day in how we treat psoriasis, in looking at psoriasis. And when we look at patients who are overweight or have significant skin folds, we tend to see more inverse psoriasis, probably because of irritation in the skin and the Kebner phenomena causing increased areas of inverse psoriasis in areas where there is rubbing of the skin and chronic trauma. But it's always important to remember that psoriasis not only impacts the skin, it affects the entire patient. And there are multiple comorbid conditions that can be associated with psoriasis. The one that I worry about most actually is depression, where people with psoriasis have been having to have clinically significant depression. Many people believe this is related to the psoriasis itself, just the presence of psoriasis on the skin. But there's an increasing body of information that looks at the inflammation from psoriasis and whether that has a direct effect on mood through impact on brain functions. Psoriatic arthritis is the comorbid disease that we think of most commonly, with about 20% to 30% of patients having psoriatic arthritis in those that have plaque psoriasis. Not always related to the severity of psoriasis. You can have people with mild psoriasis and have very, very significant psoriatic arthritis. Additionally, Crohn's disease and inflammatory bowel disease share some of the genetic makeup of psoriasis, and so that coexists very frequently. And what gets the most publicity, probably most recently, is cardiovascular disease, along with metabolic syndrome and diabetes, all of which are associated with psoriasis, particularly in patients with more extensive presentations of psoriasis. So there are many unmet needs still in psoriasis. Obviously, for those of us who've been working on this for the last number of decades, there's been a huge shift in the way we manage psoriasis. The advent of biologics, with anti-TNFs first, and then the anti-IL-23 and 17 blockers, have shown excellent safety and efficacy in the treatment of chronic plaque psoriasis. Yet, we still don't have high-level efficacy with oral medications and topical medications that allow us to personalize the treatment to the patient's wishes and what we need to use, as well as treating the issues associated with disease progression and comorbid disease. The idea that we have an understanding of the pathophysiologic pathways in psoriasis, which have led us to biologic development, also can lead us to more effective oral medications for the treatment of psoriasis. And one of those drivers for the inflammatory pathways in psoriasis is the JAK-STAT pathway. And for a greater description of that, I'm going to leave you to my colleague, Dr. Armstrong.
Thank you, Dr. Gordon, for that excellent discussion of psoriasis presentation, epidemiology, as well as comorbidities. As you have said, that it is important that we personalize our treatment for our patients, and therefore having greater treatment is something that we all look forward to better able to care for our patients with psoriasis. So perhaps here, the kind of storyline starts with let's have a deeper understanding of the intracellular players that are important in psoriasis pathogenesis. So one of these key pathways by which psoriasis pathogenesis mediates is the JAK-STAT pathway. It is important to first recognize that this pathway is not unique to psoriasis, but the JAK-STAT pathway is also used in a number of other metabolic pathways. So first of all, as you can see on this slide, in terms of the intracellular JAK-STAT pathway, this particular pathway is first activated by the binding of certain types of cytokines to the receptor. This binding then causes a conformational change in the receptor itself, and that helps to recruit the JAKs to the receptor. So JAKs work on the inside of the cell, so it's in the intracellular surface or area of the receptor. And once bound to the receptor after the activation, they actually phosphorylate, the JAKs phosphorylate the receptors, and they create these docking sites for STAT molecules to dock. The STAT molecules would dock there, and the JAKs would also then phosphorylate the STAT molecules. Once phosphorylated, these STATs can then essentially dimerize, and then they can go to the nucleus. There, they act as transcription factors and then turn on a number of inflammatory pathways, the gene transcription for those, in order to initiate the inflammatory cascade for psoriasis. And here, we can take a look at the various cytokine receptor combinations and how these combinations are associated with the different JAK pairings. So first of all, when we are thinking about the JAK-STAT pathway, as I said before, only certain types of cytokines, when they bind to certain types of receptors, they are associated then with certain types of JAK pairings. When we think about the JAK family, there are 4 main members of the JAK family, and they are JAK1, 2, 3, and TYK2. And in this family, typically 2 members work together. So for example, TYK2 can partner with JAK1 for certain types of intracellular transduction of the signals, or for example, JAK1 can pair with JAK2. So when you look at this particular slide, you will see that different pairings are associated with different types of cytokines. And this is important because it is through these different types of combinations how our body then can relay the different messages in order to have a number of downstream actions. So on the next slide here, we are looking at an overview of the JAK inhibition. So it's important to know that in psoriasis, as well as in a number of other inflammatory skin diseases, there is an inappropriate hyperactivity of the JAK activity. And most of it is because there is an inappropriately elevated levels of cytokines. And so in this particular strategy of inhibition, we are really targeting inhibiting the intracellular aspect. And here, the targets are our JAKs, and the different inhibitors can inhibit either JAK1, for example, or it can inhibit TYK2. And when we're looking at the next slide, we are looking at the development of TYK2 as one of the key target for targeting in terms of psoriasis pathogenesis. And the reason for this is that TYK2 is involved not only in the initiation of the psoriasis cascade, and that is activation of the myeloid dendritic cells, but also TYK2 is important for the intracellular transmission of the signals as a result of the IL-12 or IL-23 binding. We know that IL-23 is critical for the Th17 pathway, and therefore inhibiting that particular signaling pathway that is pathologically elevated in patients with psoriasis is something that is worth pursuing. So when we're thinking about TYK2 selective inhibitors, we are really thinking about not only controlling the quote-unquote the upstream in terms of the activation of the myeloid dendritic cells, but also dampening the inflammatory response downstream as well. Now let's talk about some of the structural differences between the JAK family. So I spoke about the JAK family having the JAK1, 2, 3, as well as TYK2. Now when we're looking at this family of molecules, they have both a regulatory domain, which is depicted on the left-hand side, as well as a catalytic domain, which is depicted in the gray color on the right-hand side. So let's talk about the catalytic domain first. And oftentimes this can be considered almost like a family, like the family's last name, for example. It's relatively conserved across the family members, for example, and especially the catalytic site where the ATP binds. That tends to be a favorite site for inhibition. And the reason for this is that you are going right to the heart of the matter. You're inhibiting where the ATP would otherwise bind. The trouble with that is that oftentimes when the site is conserved, so it's very similar across the different family members, your binding can potentially affect the actions of other types of JAKs as well. For example, we have medications that may be targeted towards JAK1, but also has some cross-reactivity against JAK2 or 3. And that can result in some of the untoward side effects that we see. When we're targeting the regulatory domain, which is the domain depicted on the left side, the regulatory domains tend to be more unique among the different JAKs. And this is, there's an analogy that this may be like the first name of the member of the family. And because this is more unique, when you are targeting the regulatory domain, it essentially causes a conformational shift in the catalytic domain. So even though you're not binding to the catalytic domain directly, the inhibitor can bind, for example, to the regulatory domain on the left-hand side, in the case of TYK2, into this pink area. That will cause a conformational change on the right-hand side, the catalytic domain, and therefore exert its therapeutic effect. So what are the key advantages of this particular type of inhibition, where you're inhibiting the regulatory domain and having that lead to a conformational change? This is what's considered allosteric inhibition. And the key advantages is that it's highly specific. The inhibitor, therefore, is very specific for TYK2 and does not tend to bind the other family members of the JAK family. And in addition to that, we see a modulation of the activity instead of complete elimination of a particular kinase activity. And this is important because we have these kinases for other normal functions in the body as well. And how do we know that TYK2 allosteric inhibition can be quite specific? Well, we have a molecule as a field that was developed called Ducavisitnib. And Ducavisitnib targets specifically TYK2, and it's a TYK2 inhibitor. So in this particular graph, what we're seeing is the level of inhibitory activity on the different JAKs as well as TYK2, which is a member of the JAK family. So as you can see here, there are different medications that have different effects on JAK1, 2, activities, and the darker gray bars represent JAK1/3 activity. We mainly want to avoid the JAK2/2 activity because this is really talking about our blood cell lines. So we want to see the lighter gray bar as low as possible. And for psoriasis, what we care a lot is about the TYK2 activity inhibition. So if you go on to the right-hand side, you see that for Ducavisitnib, there's very little JAK1/3 or JAK2/2 activity, and very specifically its activities is against TYK2. So this really speaks to the specificity of this particular inhibition. Now, in the next slide, we're looking at some of the molecular as well as the clinical effects of selective TYK2 inhibition with Ducavisitnib. So here we're looking at Ducavisitnib versus placebo in terms of its effects on total cholesterol as well as total triglyceride. So as you can see, the color bars look pretty much identical to the placebo. And this tells us that Ducavisitnib has very little effect or perturbation on the total cholesterol and total triglyceride. And this is important because the lipids are typically mediated by JAK1 and JAK2 activity. And this shows how selective TYK2 inhibitor Ducavisitnib is for TYK2, and therefore does not seem to disturb much of the normal physiology that's mediated through JAK1 and JAK2. Now, when we're thinking about TYK2 and specifically the cytokine signaling it is associated with, we typically think of three different types of cytokines. So first, as I alluded to earlier, the IL-23 is very important in psoriasis pathogenesis. And it's when IL-23 binds to its receptor, the TYK2 and JAK2 is the pairing that's responsible for carrying that signal intracellularly. Second is IL-12. IL-12 also plays a role in terms of psoriasis pathogenesis, and to carry that signal forward intracellularly, we also have the TYK2-JAK2 pairing that's responsible for the transduction of that particular signal intracellularly. And then finally, the type 1 interferon, and those are the interferons that are important in the initiation of psoriasis. So here we're talking about activation of myeloid dendritic cells, and here for the transmission of type 1 interferon, and that's interferon alpha and beta, for that signal transduction, then TYK2 and JAK1 pairing is important in that. Now, here is a table that kind of summarizes some of the effects of the different JAK inhibitions and the different immune systems or the different system in the body, aside from immune systems, that can affect. And before I turn it to Dr. Gordon to get his take on this particular graph, I just wanted to highlight, for example, in the JAK2 column here, JAK2 is essentially involved pretty ubiquitously in the different systems we have. And the part that we really want to avoid is where we're showing the checkbox of JAK2 next to the blood cell development. And so this is something we want to avoid hitting JAK2 because we don't want the inhibition to affect our red blood cells, white blood cells, or platelet production. So, Dr. Gordon, do you have any thoughts on this table?
Yeah, well, I think that it shows pretty clearly that psoriasis being an inflammatory disease, you would expect that the immune system to be critical in treating it, and any downstream effects that might be negative related to the immune system would be expected and sort of necessary in any way we treat psoriasis. And we see that today across everything we use to treat psoriasis. It's the other areas, it's the multi-organ toxicities that I think we have to always be cognizant of. And I agree with you that the blood cell development and the dyscrasias associated with JAK2 inhibition are things we sort of worry about the most when treating with other members of JAK when we talk about JAK inhibition. But I think things like lipid metabolism, especially in patients with psoriasis who often have metabolic syndrome and are obese, I think looking at alterations in lipid metabolism is extremely important. So I think all of these areas have specific relevance to psoriasis, but it's that immune mediation that is critical for psoriasis, as that's treating the disease directly.
I think that's really well said, Dr. Gordon. I think that having this table also as a sort of overview of the predominant role these different JAKs are affecting really highlights some of the specificity of the TYK2 inhibition.
Well, thank you, Dr. Armstrong. That was a fantastic description of a very complex topic that you made both very clear and understandable, which is not always easy to do when talking about the JAK family and the distinctions between the members of the JAK family. So as we move into understanding a bit about the JAK family, the specific role of TYK, we need to think about how can we practically investigate how we're going to use TYK inhibition in treating our patients with psoriasis. And so to do that, we always like to bring in a patient case, and it always helps to visualize and understand what's going on when put in the context of a case.
Yes, I agree with you, Ken. I think that for me, probably the first thing is thinking about the whether there's joint involvement is very important to me. So if they have signs and symptoms of psoriatic arthritis, then I may reach for a systemic therapy, even if they have a little body surface area. And then I would go with the IPC, the new definition, with regards to the consideration of, if they didn't have joint disease, then I would go with IPC's consideration of candidates who would be suitable for systemic therapy, as you have discussed earlier, and use that as a guidance for selecting a systemic therapy.
Yeah, I agree totally. And I think this is the single greatest, along with psoriatic arthritis, as you mentioned, greatest decision that impacts sort of the direction of the visit when we're seeing patients and how we present different medications to patients as we try to present things so they can make decisions for themselves as to what's the best treatment path for them. So going back to Bree, so Bree has plaques over in her elbows, thighs, her scalp, and some on her trunk, which leaves about 15% body surface area involved. If you're a physician, we always think about the palm being approximately 1% of the body surface area. It's pretty rough estimate, but it's helpful. And so she'll have about 15%. So this is something where she has pretty significant disease. 15%, 15 palms of psoriasis on the body is quite a bit. And so she is treatment naive. That means she hasn't gotten therapy before systemically, but it is really having an impact on her quality of life. She's a young woman going out into the world, and it's having major impact on her day-to-day thoughts and about herself and about her ability to do her activities of daily living, both from a physical and emotional sense. And so we need to go and we need to choose a systemic therapy based on both the IPC definitions, but also based on the impact the disease is having on Bree. And then we go to the factors that we use when selecting a therapy. And I think I want to start right at the top. We look at skin efficacy as a significant issue. And part of that is, if you think about efficacy being, what's the likelihood a given treatment is going to work for the patient? It's not, overlooking at populations and the number needed to treat, but in that given patient in front of us, what is the likelihood that's going to work? And that's where we talk about PASI 75, meaning that there's a percentage of patients who will reach a PASI 75. What's the predictive value? The same thing can be said for efficacy in psoriatic arthritis. In that patient who has psoriatic arthritis, what's the likelihood of this drug working for them? Safety obviously is always a major factor in making decisions. Without a good safety record, it's very difficult to choose a significant an option. Luckily, for most of our therapies that we use typically in psoriasis therapy, we have a good safety regimen, good safety record. It's why we don't use cyclosporin nearly as much as we once did. Convenience is important. Patients being adherent to the therapy. If you don't take the therapy, it ain't going to work. Cost to the patient is extremely important. I think we can consider the cost to the patient, but also societal cost. How much or what are we using going to impact our ability to get medications in the future? Previous treatment responses, looking how patients have done is important. Should we go back to a prior therapy? Should we try something new? What mechanism should we use? Comorbidities is something that I think is something we don't always consider. And I think the most important thing to remember is, does the patient have a sort of critical mass of psoriasis that drives us to say, you really need to be treated, rather than be able to go slowly, and do you have to be clear sooner than later? And finally, patient preference. Again, another area that I think we sometimes underestimate. I was at a meeting recently where a very, very well-known and very, very smart colleague said that she really tries to help patients along in making decisions and presents things that she thinks are best for the patient. I try to take the different tack to say, let me put everything out there and get the patient preference. Because sometimes if the patient feels that they have an element of decision-making in the process, they're more likely to be adherent with the therapy over time. Dr. Armstrong, what do you think are the areas that you emphasize when having a visit with the patient within this model?
Yeah, I think for me, one of the key things is safety for our patients. I think our patients' risk tolerance may be different from my risk tolerance, and I think it's very important that we have a common understanding of that mutually, because if one of us, if we're off kilter or if we're not aligned, then I know the patient is not going to continue his or her medication in the future. So I think discussion of safety is very important. And then we do have a lot of options in terms of efficacious therapies for our patients, especially in the biologic realm. And for me, conveying that information to the patient so that they understand what the likelihood of their success with the therapy is another aspect that I focused on.
Great, thank you. I think these are all really important considerations. The other issues associated with psoriasis and how we choose therapy is based on the areas that are involved, especially when we start using topical therapies or even targeted phototherapy. Now, when looking at localized psoriasis, we always have to think about what are the mainstays of therapy. And topical corticosteroids have been the mainstay for decades for our treatment. They're the most effective and also the most commonly used and to be honest, least expensive in the United States. In the scalp, for example, using solutions or lotions or foam vehicles can be very, very helpful. Now, usually to get benefit in the scalp, we'll use class 1 or class 2 topical corticosteroids, and that's usually very well tolerated in the scalp. Going down in the body or extremities, using systemics, using topicals including class 1 or class 2 topical corticosteroids is very helpful. Usually you want to limit the length of time you use these medications. But you can use them in combination with other things like vitamin D analogs or vitamin A analogs that can be very helpful. Sometimes on the body in particular, localized phototherapy can be helpful, or even generalized phototherapy that can be used as well, which is usually a little bit more available. Intertriginous psoriasis is a little more difficult. The skin's thinner. You have to be more careful about what you're using in those areas. So we use lower potency topical corticosteroids, vitamin D derivatives, or topical calcineurin inhibitors like tacrolimus or pimecrolimus, and always have some limitation on what we can use in those areas. Luckily, we might be getting some new topical therapies over the next year or so that might be helpful in having sort of single agents that we can use for topical therapy. When it comes to systemic therapies, between biologics and small molecules, we have a plethora of options, as can be shown by the fact that, 80% of all TV commercials are now psoriasis commercials? But that means that we have lots of agents, and it's a wonderful situation to be in. You have 3 basic classes of biologics. You have anti-TNFs, anti-IL-17s, and anti-IL-23s, and I tend to think of these as classes, not always as individual drugs. They have different level of efficacy, with the TNFs being extremely effective for psoriatic arthritis and maybe slightly less effective for cutaneous psoriasis. The anti-IL-23s having great impact on psoriasis, maybe potentially a little less on psoriatic arthritis. And the anti-IL-17 sort of hitting the sweet spot between the two and getting effect of both arthritis and psoriasis. As for oral medications, we have had less use of methotrexate and cyclosporin and acitretin over time. The oral medication that's used most frequently is apremilast, which is a phosphodiesterase 4 inhibitor, and that is used very, very commonly for psoriasis as well, but does have some limitations. The limitations of biologics are pretty evident. Some patients don't respond. Now, the efficacy is quite high, but there are still patients who don't respond. But some of those patients have cycled through biologics and have lost effect over time because of immunogenicity or because they have just lost response related to some other reason for breaking down the antibody or eliminating the drug quicker. Some patients have problems with the medication being administered parenterally, either IV or more often subcutaneously. People don't always love taking shots. And then finally, there is treatment-related expenses. Biologics, by and large, are extremely expensive. And even though there might be ways to get the medications to patients in the United States at a way that is at a slight discount, there's no such thing as free biologics. There's always an expense associated with them. So TYK2 inhibitors are an area where we might actually have some ability to treat psoriasis and actually gain some responses to both psoriasis and psoriatic arthritis. So far, there have been 3 medications that have been developed for psoriasis and psoriatic arthritis by blocking TYK2. One is Ducavisitnib, which is a drug that blocks TYK2 by allosteric inhibition. And that has completed both phase 3 for plaque psoriasis and is in phase 3 development for psoriatic arthritis. On the other hand, there were 2 other TYK2 inhibitors that both work by blocking the catalytic domain that have not gone on to have further study at this time. And so to date, for TYK2 inhibition, we really have Ducavisitnib as our primary player in trying to treat through this mechanism. And to look at that data, I'm going to turn it back to Dr. Armstrong.
Thank you, Dr. Gordon. Now we're going to take a deep dive into the Ducavisitnib efficacy as well as safety data. And at the end of this efficacy data, I'm going to ask Dr. Gordon about his sort of overall impression of what I presented. So we'll start with the study design. So the POETIC PSO1 and PSO2, they're the names for the phase 3 pivotal studies for Ducavisitnib, our TYK2 inhibitor that we're talking about. The 2 studies are identically designed up till week 24. And specifically, there are 3 arms: placebo, Ducavisitnib, and an active comparator arm of apremilast. Patients are randomized into one of the 3 arms, and then at week 16, placebo patients are then transitioned to Ducavisitnib. So let's take a look at the primary outcomes. So the primary outcomes are of 2. One is PASI 75, and the other one is SPGA 0 or 1. So here we're taking a look at a proportion of patients that have achieved PASI 75 by week 16, and that's our primary endpoint. Ducavisitnib, about 58% of patients achieved in PSO1 study PASI 75, or at least 75% improvement in their PASI score since the baseline evaluation, compared to about a third of the patients, about 35% patients on apremilast, and compared to 12% in the placebo group. So as you can see here, Ducavisitnib at week 16 is superior to apremilast as well as placebo. And then when we follow those lines out to week 24, we see a persistence of the effect. In PSO1, in fact, we see the rates up to 70% of patients achieving PASI 75 for Ducavisitnib. Similar results for PASI 75 was also seen in PSO2 study. Now let's take a look at the other co-primary endpoint, that's SPGA 0 or 1, or clear or almost clear. And here, the similar comparisons, the similar trends also have held here. What we see here is that 53% of the patients on Ducavisitnib achieve clear or almost clear by week 16, compared to about 33% of the patients and 7% in the placebo group. So here again, Ducavisitnib on this primary endpoint is superior to apremilast as well as superior to placebo group. Now, when we are looking at the scalp data, so now we're going to take a look at scalp psoriasis data. We know from Dr. Gordon's talk earlier that scalp is something that when you have scalp psoriasis, it can have a disproportionate impact on the patient's quality of life. Here, we're looking at proportion of patients who achieve clear or almost clear in these 3 different arms by week 16. And what was noted here, for example, is that 70% of the patients on Ducavisitnib would achieve clear or almost clear by week 16, compared to nearly 40% of the patients in the apremilast group and 17% of the patients in the placebo group. And then we follow these patients out to 24 weeks. We see the persistence of effect for Ducavisitnib as well as apremilast, but at differentiated rates as we see here. What about quality of life? Here we're looking at Dermatology Life Quality Index 0 or 1, which means that the skin disease has little or no impact on the patient's quality of life. So here, the higher the percentage, the better a medication is. And what we see in PSO1 study, for example, by week 16, 41% of the patients felt that their psoriasis no longer had a significant impact on their quality of life, compared to 28% of patients in the apremilast group. And what we see over time is that that rate continues to go up, suggesting a continuous improvement in terms of quality of life for our patients on Ducavisitnib. Next, we are looking at data that was presented at the American Academy of Dermatology meeting in 2022. And this is looking at patients who had inadequate response to apremilast at week 24. So you may recall in the PSO1 study, apremilast arm, if a patient is in the apremilast arm at week 24, if they didn't achieve PASI 50, then they were switched to Ducavisitnib. And what we see here is that in the apremilast failure group, when they are switched to Ducavisitnib, and if you follow them out to 52 weeks, on the left-hand side panel, we see that about 46% of the patients would then achieve PASI 75. So here we're talking about a difficult to treat patient population who have not responded to apremilast. What happens if you switch them to Ducavisitnib? As we can see here, we do gain efficacy in these patients with Ducavisitnib after the switch. And I think this data can be quite informative when we're thinking about patients on oral therapy and specifically on apremilast, and then to think about what proportion of them would respond to Ducavisitnib over time. So the left-hand side panel shows PASI 75, right-hand side shows SPGA 0 or 1. As you can see here, we do see response for that clinical outcome as well. And now we talked up till now mostly about the week 24 data. And when we go to our primary studies and really follow the entire cohort over time who had been treated with Ducavisitnib to week 52, 1 year period of time, what we see is that overall good maintenance of the clinical response that was achieved at earlier points throughout 1 year period of time. And here on the left-hand side, we see different lines representing PASI 75, 90, and 100, and on the right-hand side showing clear or almost clear, or as well as a complete clearance on the right-hand side. So I'm going to pause here and ask Dr. Gordon about his overall impression of the efficacy data for Ducavisitnib.
Well, I think the efficacy data, especially in a head-to-head comparison with apremilast, is pretty clear. You have high-level efficacy, probably the highest we've seen with any oral medication, short of cyclosporin, and which is limited, obviously, in the length of time we can use and the safety profile. And so I think the biggest limitation that I've seen in oral medication over time, particularly with apremilast, is efficacy. And so since you have something that's predictably has significant efficacy and probably almost twice the frequency, maybe not quite twice, but close to it, the frequency of apremilast, I think it's a major addition to the armamentarium because we're able to tell patients that we'll try an oral medication if that's what you want, and we actually have something that can pretty predictably get high-level responses.
Very well said, Dr. Gordon. And with that, we're going to dive straight into the safety summary and safety information. We talked earlier about the mechanism of inhibition of TYK2, and let's see if the clinical results bear out some of our hypotheses. So here we are looking at the safety summary for the placebo control period that's from week 0 to week 16. So here we have a placebo group, so it can be quite informative. And what is shown here is that overall the rates were pretty similar between the two groups with regards to adverse events. When we look at tolerability issues, the lower part of the table, we see that Ducavisitnib, for example, is quite well tolerated. Much of the tolerability events are very similar to placebo, and certainly numerically lower rates in terms of diarrhea or nausea as compared to the apremilast comparison arm. So the next slide shows the summary data from week 0 to week 52. As you may recall, starting week 16, we sort of lose the placebo group because the placebo patients are then transitioned to Ducavisitnib. But overall, what we see here is that, again, the same safety profile that I just talked about in terms of week 0 to 16, we see the similar safety profile in the week 0 to 52 data. Again, overall very well tolerated, and the rates of adverse events were very similar among the different groups. Now, we know while TYK2 is technically a part of the JAK family, it is important to look at some of the events of interest that have been discussed with the JAK 1, 2, or 3 inhibitors, and to look at to see if we see that with the TYK2 inhibition with Ducavisitnib. Overall, what we see is that we do not see a signal in terms of internal malignancy or skin cancer. And then also we do not see a signal in terms of serious infections or MACE events, major cardiovascular events. And of note, we do see a slightly increased herpes zoster infection rates. Most of those are localized and did not and resolved with treatment and didn't necessitate the discontinuation of Ducavisitnib. We also see slight increase in some of the acne or folliculitis rates with Ducavisitnib. Overall, again, can be managed and do not lead to the discontinuation of Ducavisitnib. There were 2 cases of VTE with the Ducavisitnib arm. One was with a patient who had a venous cannula, essentially a peripheral IV line that was placed, and that IV line was clogged. And then the other was in the patient who had a primary aortic dissection, was later on surgery found to have pulmonary embolism. However, that patient had recovered from these events and was continued on Ducavisitnib in the long-term extension study and is still currently doing well. So overall, no significantly increased signal for VTE from my perspective either. So next, we are going to take a look at some of the labels. These are the package inserts for the approved JAK inhibitors. As you can see, when the medication targets JAK 1, 2, or 3, overall what we see in terms of the package insert, there are different recommendations with regards to initiation of medication or continuation of medication around some of the hematologic parameters or liver enzyme parameters or lipids. And most of this is derived actually from the rheumatoid arthritis patient population, where they have seen some perturbations in some of these parameters, and therefore these recommendations are applied across the different JAK families. Let's take a look at with regards to the laboratory data for Ducavisitnib. So here you see cholesterol, creatine phosphokinase, neutrophils, as well as platelets. And I would challenge you, if you didn't read the legend here of what the different color lines represented, you can probably see it is very similar in terms of laboratory parameters, whether we're talking about placebo, apremilast, or Ducavisitnib, really showing the lack of effect on Ducavisitnib on the laboratory parameters that we care about. And I think that's an important point to note in terms of the safety for Ducavisitnib. In addition to psoriasis, Ducavisitnib is also being evaluated in a number of other conditions such as psoriatic arthritis, inflammatory bowel disease, as well as lupus. And here is the study design for the ongoing phase 3 psoriatic arthritis study, which I think we're all very excited to see in the future. And the reason for that is that the phase 2 study, which is shown on the left-hand side, have shown a response of Ducavisitnib in the joint signs as well as symptoms. And now when we're looking at TYK2 as a target for inhibition, here is a slide showing a number of different molecules that are under development for TYK2 inhibition. As you can see, there are 3 others that also targets the allosteric domain, really showing that that's a good good part of the protein to target with regards to drug development. So I think the future of TYK2 as a whole class looks pretty bright, with more players potentially coming down on the pipeline. Ken, any thoughts on how long you would continue Bree on trying apremilast before thinking about switching her onto different therapies?
Well, the common teaching is that within 2 to 4 weeks, most of the side effects, tolerability side effects of apremilast will improve. But there clearly are patients who have persistent issues. So I usually tell a patient, if you're going on 4 weeks and still having persistent issues that make an impact on your life, it's time to go somewhere else. And one of the things I think we need to figure out is how long do we have to wait before we see enough efficacy to determine that it's time to change meds. And that's one piece of information that we don't have with apremilast, though it's my suspicion if we have people who are showing moderate responses at 6 to 8 weeks, you might want to go on. People who aren't showing any good response by that time, it's time to change at that point as well. So I usually give it a few weeks, see how those tolerability side effects improve, and then move onward after that.
Great points. I also think getting back to the tolerability issue, sometimes I do encourage my patients to stay on the drug for a little bit longer to see if their tolerability issues discontinue. But as we know, most of our patients, it's hard for them to live with nausea and diarrhea for a prolonged period of time. So understandably, sometimes I find that they would self-discontinue the medication at a much shorter time period than I would recommend them to potentially continue trying to see if some of these side effects go away. So what if the Bree, if we talked about Bree, who's 25 years old, but it's important to know, what if Bree were, slightly different? What if we were talking about a woman who is 65 years old, and what if Bree has psoriatic arthritis and these other comorbidities as something for us to think about, because in real life we see patients from really diverse backgrounds. So taking that into consideration, I just wanted to ask Dr. Gordon, if Bree were a 65-year-old woman, what would you do differently or the same?
I think particularly age is sort of a relative thing with therapy for psoriasis, because the side effects or the infectious concerns you have are escalated, but they're escalated in pretty much everything we use. And when you look at a medication in the oral medications, we feel very comfortable using apremilast because we don't really see significant increases in infectious risk, for example. But if you look at the head-to-head comparison between Ducavisitnib and apremilast, they seem to be about the same. And so I think that you can feel comfortable using either of these agents in patients who are over 65. Likewise, I think the psoriatic arthritis data leads you to think either in a biologic, but also into some of the oral agents. Importantly, I think the severity of psoriatic arthritis comes into play. If you have no real, the 10 swollen tender joints is different from a patient who has a modest amount of joint stiffness in the morning. And so I think that makes a difference in terms of what you would choose. But in general, I think having data that supports use in psoriatic arthritis is important as well. The one I think is most important is the difficult to treat areas, particularly the palms and soles, where I think our experience suggests that small molecules might do a little better than biologics, and probably it's a delivery issue. So I think that that's something we need to keep in mind if she had significant amounts on her palms and soles and driving you towards using an oral small molecule.
Those are all great points, and I think that I agree with you in that when we're looking at our current oral therapy, specifically targeted small molecules, I think the age of the patient, I think I would consider apremilast or Ducavisitnib being both appropriate for those with older patient populations. So I think I'm going to turn the floor back to you, Ken, on to really think about where TYK2 inhibitors fit into our treatment algorithm.
Well, thank you, Dr. Armstrong. I appreciate that amazing presentation of a just tremendous amount of data, very, very clearly, and it's really easy to understand. So when you put all of this together, we think about where we consider using TYK2 inhibition. We always look at systemic agents as a whole. We look at the oral medications specifically as a class, the traditional ones, significant end organ toxicity and multi-organ toxicities that really have limited their use over time. Apremilast may be more tolerable, tolerability issues rather than safety. The JAKs in general, the classic JAKs that block the binding sites and are competitive inhibitors, we have significant impact because of cross-reactivity, infections, thrombosis has come up, and obviously the blood test changes that we all have to follow when we're using the classic JAK inhibitors. The allosteric inhibition used by Ducavisitnib might be significantly advantage because it doesn't have that cross reactivity with the binding sites, and therefore you can have a more specific medication for the treatment of a disease like psoriasis. When thinking about it versus apremilast, so the oral medications approved for psoriasis, again, the efficacy is going to be greater, and that's been demonstrated head-to-head. Tolerability will also be significantly greater, we think, at least particularly in the early portions of therapy, because of the diarrhea and nausea and headache associated with apremilast. What's really important, I think, in the head-to-head trials, though, is that the safety, which we feel very comfortable with apremilast in terms of safety with infection or various other mechanisms and blood tests as well, seems to be almost identical between Ducavisitnib and apremilast. And that gives me a lot of sense of comfort using Ducavisitnib because I feel very comfortable from a safety perspective with apremilast. And I think it's important to compare these things head-to-head. So for moderate severe psoriasis overall, I think safety, tolerability, its efficacy, all are play big roles. Taking a pill once a day is something that is, I think, tolerable to most patients. The impact on comorbidities, we are hopeful that we'll see things persistent psoriatic arthritis. The inflammatory bowel disease data might be very, very significant. And so we believe that Ducavisitnib is going to be a major advance in the treatment of plaque psoriasis. So to conclude, we've looked at our understanding of the epidemiology and the pathogenesis of psoriasis and how some agents can impact safety and efficacy, but we need to look at how these things impact our patients going forward as we sit in front of them and talk to them. There's still a significant unmet need for which oral agents that have safety and efficacy are still sought after and highly significant, will be used in the clinic. TYK2, we've seen, regulates immune functions by blocking IL-23 in particular, but also IL-12 and type 1 interferons. It's now been successfully targeted in psoriasis at a late stage of development with Ducavisitnib, and the data really does confirm what we are hoping for the treatment of psoriasis. So, as I said, we have an unmet need, and conventional therapies haven't been successful. Apremilast is a useful agent that we do use very frequently in psoriasis, but there's still an unmet need for a high-level efficacy. And so I'd like to thank Dr. Armstrong for all of her insightful comments in today's seminar. It's always a pleasure to have a chance to work with you, April, and I think it's been great to have a chance to hear your perspective on medications blocking TYK2 and its impact on psoriasis.
Thank you, Ken, for a very stimulating and engaging conversation today.
And thank you very much, and I hope you've all enjoyed our seminar on the impact of TYK2 in the treatment of psoriasis.
This activity is certified by PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/CCT860.